thank you so much, and to the co-chairs, the chairs of STI 2018. You can see that I'm running from one meeting to another here, way too many of them on the go. And in fact, Patrick, lovely to hear that just as I came in the door, because I've just come from an adolescent meeting. And definitely a lot of enthusiasm around mobile and e-health there. So I think a lot for us to think about. But a real pleasure to be here. Thanks to Ken and Henry for this opportunity. And I, sort of between us, the idea here was really to think a little bit about syndromic management of STIs and put our reflection. I know I'm preaching to the choir here. Nevertheless, it's important to just put a bit of reflection around the future of syndromic management of STIs. So what do we know about the STI epidemic in African countries? Well, I think you guys probably, again, don't need to be told too much, but I'd start by saying that that's a worldwide non-focus on STIs also is very alive and well in Africa. We have limited data on STIs, in particular data disaggregated by sex and age group. I think there's inconsistent reporting, and a lot of it, again, is based on estimates and modeling. We do need better data. So measure the progress that we're making towards the control of STIs is not going to be possible unless we collect better data. And we do think this is a priority area for action, and so I'm really hoping that these kinds of meetings will again show a spotlight. And because we have such a huge focus on HIV in Africa, we hope that we can ignite the need to really rejuvenate the STI field in that regard. This is a busy slide, but just to say there are some data out there. Here's some data on gonorrhea in Zimbabwe, Morocco. You see some evidence of chlamydia prevalence, high rates here in Nigeria. HSV2, this is a little bit old data, but just to make the point that obviously there are lots of STIs in Africa as well. I want to hone in a little bit on some of our own work, because I've been really alarmed as we've gone in with diagnostics to discover that we seem to be having a veritable epidemic of chlamydia, certainly in Cape Town. Here you see almost 1 in 2 young women, mean age 18, in an area where we work in Cape Town, and slightly less in Soweto. But these are young women who are just debuting, totally asymptomatic, and these rates of 11% gonorrhea, as I say, 42% chlamydia, and increasing HSV2 as they age. 71% of all participants had at least one STI or BV, and 28% had both STIs and BV. So here we show it by age, and you can see that the prevalence of STIs is higher in younger women than the older group. So I think definitely with perhaps patterns of sexual activity at that age group, maybe the inability to be able to ask for male condoms in that setting, I think really very concerning, and something that I think we all need to be thinking about, particularly, and I know this is the theme of today's panel, as we're thinking about pre-exposure prophylaxis rollout in this age group. Here's another paper now published where 60% of HIV-negative South African women at high risk for HIV had either an STI or BV, and 20% had more than one infection. That's from the Caprisa group. Most of them, I make the point, are asymptomatic. Here's another study we've just been doing together with CAFED, looking at the role of Gene Expert, and again, chlamydia, 42% in the setting. It's taking the Gene Expert into a mobile vehicle and moving around in a number of townships in young women. These are young women between the ages of 15 and 21. And this data will be presented at the main conference, Marcus et al., so I just alert you to that. Patrick did a very nice study amongst young men who have sex with men together with us in Cape Town. It was to look at a sort of prevention package for young men, and we looked obviously at HIV prevalence there. You can see high rates of HIV prevalence, 35% in the 18 to 19-year-olds, going up to almost 1 in 2 in the 30 plus. So clearly HIV a real factor amongst MSM. But when we again looked at STIs in this population, at any site and any organism overall, out of 300 odd men, 42% of them had an STI. And again, there the numbers I've circled for rectal gonorrhea, rectal chlamydia. And I'll come back to this in a moment in terms of symptoms in that population. The good news is we are having some successes in Africa. We've seen a decline in chancroid, decreased incidence in the general population of syphilis, and a few other, and happily increased access to HPV vaccination has shown to reduce pre-cervical cancer lesions and genital warts. So South Africa is one country that is rolling out HPV in our 9 to 12-year-olds, and so we're hoping to see that pattern expand as we go on. So what can I tell you so far? Well, of course, STIs are alive and well in Africa. Many of them are asymptomatic. I'm concerned about adolescent and young women, young girls, and the MSM population in this regard. And really, I think we have an inadequate focus on sexual health services. So what are we doing about our STI epidemic, and what's our approach? Well, as you know, there are these 3 approaches, that of using laboratory tests and being very targeted, using clinical experience, and giving treatment targeted suspected pathogens, this notion of the clinical syndrome and giving treatment of all of the locally known pathogens which could cause a particular kind of syndrome. And it's the 3rd, syndromic, which is our standard of care at the moment. And this is per WHO syndromic management guidelines. So why syndromic management? Well, of course, this was based on the identification of consistent groups of symptoms. Few African countries really had the health facilities or the laboratory equipment, or indeed the skills perhaps, to make etiological diagnoses. And so the syndromic approach was born. Why? And again, compared to others, well, it really is about facilities, cost, time, expertise, and so this has now become an ingrained approach. There is some evidence for it. So treated in Rwanda compared sensitivity of 3 approaches for patients with genital ulcers. Treated for chancroid and syphilis, it correctly managed 99%. Choice of treatment based on lab tests for syphilis, correctly managed 82%. Treatment indicated on clinical diagnosis alone without laboratory tests, correctly managed 38.3%. So conclusion, a simple syndromic approach should be used for case management. Using the syndromic approach, 70% of genital ulcers were currently diagnosed in a paper from a long time ago, 40% of chancroid, 24% of syphilis there in Nairobi, Kenya. And in terms of cure rates, again, you see those studies from Zambia and Cote d'Ivoire with reasonably impressive cure rates. The differences in cure rates reflect factors such as the definition of cure, the choice of the drugs, the compliance, of course, and antibacterial treatment. So there has also been this sort of relationship with HIV, and we all know the Mwanza intervention trial, where communities were randomly allocated to receive improved STI case management with a 42% reduction in HIV incidence, a 30 to 50% reduction in active syphilis and symptomatic male urethral discharge. Syndromic management achieved clinically assessed cure rates of 91% in Abidjan and 96 to 98% in Mwanza. Cost a factor. Without other approaches, atypical clinical features, false negative results, or mixed infections may, of course, be inadequately managed. and patients may return for further investigation, suffer prolonged morbidity, and need retreatment, which of course incurs further costs. The cost per patient cured by the concomitant syndromic approach may therefore be cheaper, and of course that led very much to the WHO recommendation of old, and this here you see a sort of a historic timeline of our guidance from WHO, and here we are in 2016 with an updated guideline due to concerns of resistance, a strategy towards ending STIs by 2030, and STI guidelines as individual infections moving away happily from the syndromic approach. So now WHO recommends that countries start using the updated guidelines immediately as recommended, and these new guidelines are also in line with the Global Action Plan on antibiotic resistance, which came out of the World Health Assembly in 2015. So why should we move away from syndromic management? Well, I hope you've already realized we're obviously over-treating. We have some emerging resistance, and those are all good reasons to move away. Just to make the point that that is not only a problem in Africa, and obviously it's a worldwide problem, but we have insufficient notion of what is happening in Africa, and that's obviously concerning. In addition, there is this notion of asymptomatic infections, particularly as I've illustrated amongst young women and also men who have sex with men. And just to make that point, Patrick, from your study, Sabanya, here is sort of a look at symptomatic presentation and then the laboratory diagnosis. That at baseline of those with a biologically confirmed STI diagnosis, 8% had a symptomatic STI diagnosis at that time. And at 6 months, it was 6%. At 12 months, 15%. So really, I think making the point that most are asymptomatic, and we're missing a lot of these infections. Again, concerning as we move into pre-exposure prophylaxis. I won't belabor this point, but here is coming out of that STAX study, which you can see the poster of on Wednesday, really inadequate use of syndromic management on its own. And here's the same numbers for the gonorrhea out of that study. So really, STI symptom screening as a good test for gonorrhea, not at all. So hopefully, I think, I hope the syndromic management era is coming to an end for the reasons that I've already said. And even the WHO risk assessment to improve sensitivity and specificity of the algorithm, I think, hasn't been very successful. So the simplistic nature has become an automatic clinical response and really unable to monitor, in addition, etiological STIs and therefore plan accordingly in country. So over time, countries should be assisted to move from syndromic to etiological surveillance. That's the 2016 strategy, and we are seeing that coming through in our guidelines now. We do have our global targets, which ask, and I'm sure this has been spoken about today and yesterday already, and so I'm looking forward to the new 1990 goals to really be that we hone in on gonorrhea, on syphilis, and on chlamydia as well. So chlamydia, gonorrhea, and syphilis are major public health problems worldwide. The new WHO guidelines reinforce the need to treat these STIs with the right antibiotic at the right dose and at the right time in the right way. So unfortunately, most countries are still using a syndromic approach. Kenya is beginning to move in the right direction, and I'm pleased to announce my country, South Africa, is also moving in this direction. So what do we want? Well, we want etiological surveillance. We want to reduce these STIs. We want this by 2030, and so I think we have to remove syndromic management as soon as possible. And that means we need expertise, training, infrastructure, testing, antibiotics, and funding. And I know you will have spoken about the various ways to do this. I think getting this out to Africa is going to be really important for the key populations that include young women. And that will help us reduce fetal and neonatal deaths, cancer, infertility, increased HIV risk, and all the other ills. And I know this panel's been dealing with some great ways to do this. I think Africa will be ripe for integrated sexual reproductive health care that involves all of those very important topics. And I just want to throw in there, has to include pre-exposure prophylaxis. So I'll stop there, say that pre-exposure prophylaxis is on its way. And really, I hope that when we come together in San Francisco in 2020, we'll be able to talk about how syndromic management is beginning to fall away in Africa. So the world needs sexual health services. I want to thank my team who helped me put this talk together. But really, to put out that, I hope you've all had a chance to browse the IAS Lancet Commission. There's a real call out there that STIs and HIV, sexual reproductive health services, have to come together for common cause. And I hope that in the next 2 years we'll see some progress in that regard. Thank you so much.